And with that, I'd like to introduce Dr. Bedimo, who will be our first speaker of the day. As you heard from his initial introduction, he's a professor of medicine at the University of Texas Southwestern Medical Center and the chief of infectious diseases at the VA in North Texas. His research interests include the analysis of rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy, as well as the contribution of hepatitis C co-infection on HIV-associated morbidity. Dr. Bedimo is also the clinical research site leader for the ACTG and a member of the Department of Health and Human Services HIV Treatment Guidelines panel. Welcome, Dr. Bedimo, and please tell us how not to go gentle into that good night.
Rage, rage against the dying light. That is how. Now, what we'd like to do in this course today, in the 15 minutes that I have to introduce it, is to show you how we propose we handle the growing aging in the people with HIV. And these are my disclosures. And after attending this presentation, what we'd like the learner to be able to do is to prepare for a deeper dive that my co-presenters would delve into later on topics that include immunization, frailty, cardiovascular health, cancer, and mental health. Now, we are aging, and let's first define by what that means. You could look at it literally as a chronological age. The UN actually has a definition for it, people age 60 and above. And it also varied by site, depending on how long people live in those areas, as I mentioned here, in sub-Saharan Africa and in Japan. But that is our chronological age. The functional age is what we will have Dr. Ellenson tell you more about, is focus on the person's physical and cognitive abilities rather than the years that they live. And that's the concept of frailty that we will mention later. Then you have social age. Let's consider how an individual fits into society's expectations for the age group, the roles and behaviors and habits. And then finally, psychological age, we relate to the capacities, including learning, memory, intelligence, and emotional regulation. Now, there is a concept of successful aging, which is what we'd like all of us to be. We like to successfully age, and we like to help our patients successfully age. And this is what people have begun to define successful aging as: minimizing the risk of disease and disability, continue engagement with life, and maintain physical and cognitive function. I must submit to you that for people with HIV, antiretroviral therapy is now the low-hanging fruit. What we like to do now is to prepare our aging patients for a successful aging. And this is what this course is all about. So, and life expectancy in people with HIV has continued to increase. And this is the price of remarkable practice of success for antiretroviral therapy and the prevention of post-sick infections. You see here in the gray line how much survival of people with HIV departed from uninfected control, which is the orange line here. And then every 5 years or so, the survival of people with HIV has inched closer to that of the people who are not living with HIV, and it has continued to do so in the recent years, especially for people who were diagnosed after the year 2015. Those are the solid lines, red and blue, and especially for those who live without substance use disorder, and those are the blue lines. The red lines, people who live with substance use disorder, tend to have a shorter survival. So this is the good news. But with aging come what we call the four horsemen of the apocalypse, the four chronic diseases, the four categories of chronic diseases that seem to catch up with us as we age: cardiovascular diseases, MI and stroke, malignancies, neurodegenerative diseases, and metabolic diseases. And what we want to focus on in this course is, do these four horsemen of the apocalypse come for you earlier if you live with HIV? And there is an evidence of accelerated aging in people with HIV, which is defined or evidenced by markers of immunosenescence, shorter telomere length, epigenetic age advancement. So we can consider HIV as a canary in the coal mine. This is a harbinger of things to come for the general population. So if we focus on these issues in people with HIV, that actually prepares us for focusing on them in the general population. Now, again, price of success, people with HIV are aging. And over 50% of people with HIV now are over 50 years of age. And this was evidenced by the answers to questions that you were posed earlier. And the age-related comorbidity burden is also increasing. Almost half of people with HIV by 2030, a mere 5 years away, will be living with two or more physical comorbidities. Almost two-thirds will be living with one or more mental comorbidities. So it behooves us, all of us, to very much either prevent those that we can, and we talk about immunizations and others, or manage those that we cannot prevent. Now, enters the naked mole rat. This is not a family pet, people. It's a rat that I like to take as an example of an animal that has figured out how to age successfully and live for a long time, more than 30 years, compared to mammals of its similar size will live 2 to 3 years. And this is through a mixture of biological, genetic, and environmental factors. And this is exactly the kind of framework we'd like to look at. What biologic things can we tweak? We cannot tweak genetics yet, but also what environmental factors can we tweak to mimic the naked mole rat? In terms of genetics, that it has figured out how to stabilize its gene, efficient DNA repair, and low oxidative stress. It also has figured out how to resist cancer more than other animals because they produce a unique form of high molecular weight hyaluronate, which prevents from cells from crowding and dividing uncontrollably. So this is a very powerful anti-cancer mechanism, and early contact inhibition is another mechanism. In terms of metabolic and environmental adaptation, it has figured out how to live and survive in low metabolic rate and low oxygen tension. So it successfully lives in extremely low oxygen levels by burrowing in these tunnels. I don't invite everyone to go in a tunnel with low oxygen, but we need to understand what organisms that age successfully can teach us. But the last one that I actually want to focus on is social and lifestyle factor. Do we have lessons to learn from this? Absolutely. The naked mole rat lives in stable, cooperative colonies, reducing stress and risk of exposure compared to solitary animals. And it has a stable environment. So when we think about social determinants of health, that is nothing different from this. So, and finally, this is the newest and hot off the press, showing us how through mutations in this gene called CCAS, or cyclic guanosine monophosphate, adenosine monophosphate synthesis, it has figured out how to resist changes that are imparted by infections, viruses, bacteria, and other cell damage that increase type 1 interferon, cell death, and senescence. So it has figured out how to stabilize its gene by protecting it from the changes that are imparted by this. So why did I talk about the naked mole rat? Because it allows us to move to the rest of our course today. What are the challenges we're facing? Early onset of cardiovascular, renal, metabolic, and cognitive disorders, polypharmacies, drug-drug interaction, functional decline, frailty, falls, mental health concerns, depression, isolation, stigma, health disparity, and access to geriatric care. Half of you don't even have access to a geriatrician. So we all have to do this ourselves. And then how do we prevent and managing the situation? Comprehensive risk assessment and early screening, lifestyle interventions, exercise, nutrition, smoking cessation, tailored immunization strategy. Dr. Spark will mention that to you, integrated care models. We have to be prepared to work seamlessly with our colleagues who are in a geriatric care and then other specialties. And then we really, really need to address the social determinants for health. Our patients need to know that we are a safe environment. We know the environment is challenging outside, but we want to be able to counter those challenges so that we impact the health of our patients. So today's agenda, successful aging with HIV, we want to rage against the dying light by understanding the science of aging. That's what Dr. Michael Colley will do. Vaccines and immunizations, this is what Dr. Spark would tell us. And looking at frailty, this is what Dr. Evanson would mention, and overcoming clinical inertia with heart health, Dr. Longnecker would discuss. And then also cancer risk in aging with HIV, Dr. Cockhill will mention that. And then we'll close with cognitive and mental health in older adults. This is what Dr. Faradian would show us. So we go back to successful aging. Dealing with all these things will allow us to minimize the risk of disease, continue engage with health, and maintain physical and cognitive function. And it allows us to stave off the arrival of the four horsemen of the apocalypse. Cardiovascular diseases, Dr. Longnecker will tell us how. Malignancies, Dr. Coghill will tell us how. And neurodegenerative diseases, Dr. Faradian will tell us how. And then finally, metabolic diseases and frailty, which is what Dr. Ellenson will mention. So we need to move from survival to strategy in terms of the aging with people with HIV, successful aging. So it's a success story, but it's a complex challenge. And it's the science reveals us that early warning signs and intervention windows do exist. We need to seize them, and that includes immunization and preventive care. With knowledge, collaboration, compassion, we need to resist the decline. We need to commit to aging with agency and excellence in care. We need to rage against the dying light of the light. So thank you, and I'm looking forward to questions and the further discussions with my co-presenters.
Thanks, Dr. Bedimo, for that really excellent introduction and laying the groundwork for today. While we're waiting for any questions, audience members, please include any questions in the Q&A. I wanted to ask you, as we address these horsemen and kind of aging, ideally, it would be great to have a pharmacologic treatment that could address many of these horsemen and kind of the complications of aging that we experience with many different comorbidities, especially with HIV. Do you foresee a magic pill or a poly pill or some sort of treatment that we could use that would prevent many of these aging complications? Or do you think it's really the naked mole rat model of living in a low oxygen condition in a tunnel?
Yeah, I have a survival strategy. I'm gonna dig myself a tunnel, live there with no interaction with the external world, and I will live forever. No, I mean, I think that we are beginning to understand just how these four major categories of chronic conditions will impact our life and shorten our survival. And with science, we're going to learn that, especially like Dr. Longnecker we mentioned to us earlier, cardiovascular diseases, by and large, we have tools to stave off the arrival. And you will tell us how to manage the frailty. Dr. Spark will tell us that with immunizations, we can actually decrease a lot of the complications that will lead us to demise. And just recently, it looks like immunization has gotten a black eye, and we need to look out for that. But science is progressing, and right now, looking at these mutations, for instance, that the naked mole rat has, it's not possible to through CRISPR and other things to impact these mutations that would lead people's genetic materials to resist the changes that are harbinger of accelerated aging. So there's a lot to come from science of the science of aging, and just understanding what works is important. And let's not forget that uh, studies in places that are the blue zones, like in Okinawa in Japan, has shown that two things predict successful aging better than anything else. One is physical activity, and the second one is social connections.
Mhm.
So our patients will feel ostracized and socially disconnected. We're doing them a disfavor.
Yep. Excellent. A couple of questions in the Q&A. One is, what are your thoughts about co-management of our patients with HIV who are 50 and older? Do you think that the ideal model should include co-management with geriatricians or with internists or family med who are very familiar with senior geriatric issues? Or do you think that this is something that HIV clinicians alone should continue to manage? Or what's the best model moving forward?
Yeah, I'm a big advocate for co-management, but with a caveat. We all saw in the polling earlier that most of us don't even have access to a geriatrician, and it's a luxury for many. And but also the fact that we tend to have a closer connection with our patients than the subspecialists that we might call on to assist us. It compels us to at least have an idea of how to begin to address these conditions, even if we get support from specialists from cardiovascular medicine, oncology, and metabolic disease and mental health. So I think that co-management is important, but it needs to be mindful of the context we're living in.
Yep. Something that I don't think we have on the agenda included in our presentations today, but something that came up in the pre-questions is how do we think about aging differently in people who were perinatally or who perinatally acquired HIV? And do we consider someone who's 30 that acquired HIV at birth similar to someone who's 60 that acquired HIV at age 30? Or how do we think about aging in the context of perinatally acquired HIV?
Yeah, actually, this is an excellent question, and we're just beginning to understand this, of course, because the cohort is small and fewer studies have looked at the aging of people who were prenatally acquired HIV. And so I believe that we can ask later on if we can understand from the science of aging that Dr. Colley will present whether the epigenetic age advancement is even more accelerated the longer you live with HIV. There are some studies I'm aware of, like in Southern Africa, like in Eswatini, that have looked at the uh, epigenetic age advancement markers for people who acquired HIV when they're already old, and the people who aged with HIV acquired in early adulthood. That may shed a little bit of light to what we should expect from people who are perinatally acquired, but it's pure speculation on my part.
Yeah. No, I think it's a definitely of growing interest, especially as that population is becoming a larger portion of our adults living with HIV now. And there was also a question from an audience member in New York who asked about just some differences in the approach to aging in general versus aging in HIV in regards to impact on kind of geriatric syndromes. I know some of this we'll get into later, but what about things with vision and hearing? Do you think about those in your clinic population? Is the approach any different than what we would take with the general population? If you happen to know, otherwise these may come
Yeah,
up later in today's presentations too.
yeah. So, I mean, again, I can offer a partial answer to that, which is the part that I know. And is that a simplistic model is that people with HIV are subject to the age-related conditions
Mhm.
earlier. So the so-called accelerated aging, which is something that may be a little bit of an oversimplification because some things like malignancies, if you look at the risk ratio of different malignancies between people with HIV and without, they're not linear. I mean, it changes like earlier on and later on in life. So I think it's important for us to say that at the minimum, we should abide by the screening and prevention tools that are accessible, available for the general population, apply them earlier when we know the guidelines recommend it. For instance, um, uh, 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 for bone mineral loss, we do DEXA scans at 50
Mhm.
rather than 70 for the general population in males. And the screening for malignancies and others. But these are just the thing, and we just learned, and Dr. Longnecker would mention that to us, that for primary prevention of cardiovascular disease, we need to be more aggressive. That's what Reprieve told us. And
Mhm.
but so these are the kind of nuggets of information that allows to manage prevention, screening, and management of age-related complications in our patients with HIV, while the data specifically on people with HIV is still sparse.
Yeah, and I think we've seen the Max Weiss combined cohort study has done some nice collection of data on sensory issues like vision and hearing. And some may or may not occur more commonly in HIV, people with HIV, but I think it's at least important to recognize those as contributors to other aging conditions. We know that hearing loss can impact cognitive function, that Dr. Farhadian will talk about later. So just being aware of these conditions and making sure we're screening for them. So. Okay. I think we had one question, which I'll just briefly kind of mention as something to think about. I don't think it's something we've dealt with nearly as much in the HIV clinic these
Mhm.
days, something that certainly came up quite a bit more. But what are your, and I think this probably varies quite a bit from state to state, but I think as our patients with HIV are experiencing greater and greater burden of kind of chronic terminal illnesses, the issue of
Mm.
death and dying has also come up, and trying to make sure that we're treating people respectfully and kind of fulfilling their wishes at the end of life. And something we don't cover in today's presentation, but I think that's also an important topic. If you have any comments or anything you want to mention on kind of that topic of death and dying and helping patients at the end of life.
Yeah, I think as physicians, that's just gonna be like my own view of this. We are too timid about addressing the inevitable
Mhm.
in our patients because we think it's too gloomy a topic to mention. But patients really appreciate it if we proactively mention that there is going to come a time when you need to make arrangements for so and so, and then making sure that the 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 later years and the later days of the lives are lived with dignity and in conditions that they would choose. I think that as a society, we're too interventionists, and we will not usually allow people to 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 live in dignity the last days. And I think that for us who see people who are closer to that time, it's important to be mindful of that.
hmm Yeah, and I think something we've done, looked at just in our clinic population here in Colorado is the number, making sure that people have completed at least an advance directive and kind of
Mhm.
designated a medical power of attorney. And it's surprising the number of people who have not. And at least having that conversation of making sure they have somebody making those, helping to make those decisions for them and bringing it up when people are young and healthy. So it's not a discussion that scares patients if you bring it up and they're like, "Do you think I'm dying?" It's more of a
Mhm.
proactive discussion on, "Hey, let's
Mhm.
think about this while you can and while you're young and healthy and can make decisions that you want." So, Great.
Well said.
Well, thanks, Dr. Bedimo. I think this was a great introduction, and we look forward to moving throughout the day and several other presentations. I'm going to turn it over to you now to introduce our next speaker, Dr. Corley, who I believe is ready on the beach in San Diego, and look forward to the next presentation. Thank you.